Welcome to this deep dive. Today we're going to explore a specific condition in veterinary medicine called polycythemia. We've got a detailed veterinary guide on the subject as our source material for this deep dive.
Yeah, and our mission is to really uh, unpack this for you to understand exactly what it means, why it happens in the animals we care about, what it looks like, and ultimately how vets figure out what's going on and what they actually do about it. We're pulling out the most important info from this guide to give you a clear picture.
Okay, great. Let's jump right in then. What is polycythemia according to this source at its core?
Well, at its most basic, the guide defines it as an increase in the packed cell volume, that's the PCV, along with an increase in hemoglobin concentration, and, well, the actual red blood cell count itself.
So basically, too many red blood cells floating around.
Exactly. And importantly, this increase is above the normal reference intervals you'd expect for that specific animal, considering species and even breeds sometimes. But here's one of the first key insights. The guide makes it really clear that not all increases are the same. It can be due to a relative, a transient, or an absolute increase in circulating red blood cells.
Okay. So how you get to too many really matters. Different pathways.
Precisely. It's the consequence of different underlying processes.
Got it. Which I guess brings us to the pathophysiology, how the body actually makes red blood cells and how that system might go wrong.
Yeah, and what's fascinating here is how incredibly tightly controlled the number of circulating red blood cells normally is. The body has this precise system to keep it just right.
Right. And the guide points out several factors that play into this control. We're talking things like changes in plasma volume, the fluid part.
Changes in plasma volume, the red cells are destroyed or lost, splenic contraction.
Splenic contraction.
Er,
Okay.
Yeah, the spleen holds a reserve. And crucially, the secretion of erythropoietin and EPO, that's the main hormone, mostly from the kidneys, signaling the bone marrow to make more red cells. The guide also mentions other hormones influencing this whole process, things from the adrenal cortex, thyroid, ovary, testes, even the anterior pituitary gland.
Wow. Okay. So it's not just kidneys and bone marrow then. It's a whole hormonal conversation happening.
It really is. The guy highlights that this normal count is maintained by a pretty complex endocrine feedback loop.
And when that loop gets disrupted or other things interfere.
That's when you can see polycythemia. Which brings us back to those three classifications you mentioned.
Right. Let's break those down. Maybe start with the most common one, relative polycythemia.
Sure, relative. This is typically caused by a decrease in plasma volume. Almost always it's dehydration.
Dehydration. So, wait, the total number of red blood cells in the animal's body hasn't actually changed, but because there's less fluid, they just seem more concentrated.
Exactly, you got it. Like having the same number of swimmers in a pool, but someone drained half the water out, suddenly looks packed.
Okay, that makes sense.
Yeah, the red cells themselves aren't increasing in number, the fluid they're suspended in is decreasing. The guide calls this hemoconcentration. Very common finding.
Okay, common. Good to know. Next up was transient polycythemia.
Transient, yeah. As the name suggests, it's brief. It's caused by the spleen contracting. The spleen basically injects this stored, highly concentrated batch of red blood cells it keeps on reserve into the general circulation.
Huh. Like the spleen's got an emergency stash?
Sort of, yeah. It's a momentary protective response, usually triggered by epinephrine, the fight-or-flight hormone.
Right.
And because it's so short-lived, the guide notes it's usually not a major diagnostic headache when looking for ongoing polycythemia. It just happens, then it's gone.
And what triggers that epinephrine surge? Distress.
Things like excitement, anxiety, seizures, or even just the stress of being restrained for a vet visit can definitely do it in some animals.
Yeah. Okay. So, dehydration causes relative the spleen squeezing, causes transient. That leaves absolute polycythemia.
Absolutely, yeah.
The guide says this is a true increase in the total red blood cell mass because the bone marrow is making more.
Right. This is where the bone marrow itself is actually overproducing red cells. And the guide divides this further into primary or secondary types.
Okay, let's start with primary absolute. Polycythemia rubra vera, it's also called.
That's the one. It's a rare condition. The guide describes it as a myeloproliferative disorder.
Myeloproliferative. Sounds serious.
It is. Think myelo for bone marrow, proliferative for growing rapidly. So it's essentially a type of, uncontrolled growth originating in the bone marrow, like a cancer, basically. The key here, which is interesting, is that it's an uncontrolled but surprisingly orderly production of excessive numbers of mature red blood cells.
Orderly? That seems odd for uncontrolled growth.
It does, doesn't it? But that orderly production of mature cells is characteristic of this specific, rare primary type. The bone marrow is just churning out red cells without needing the usual signals or ignoring the stop signals.
Okay. And then there's secondary absolute polycythemia. This one does have an external trigger, you said.
Yes, exactly. The guide lists two main ways this happens. First, the body releases EPO appropriately, but it's because there's chronic low oxygen levels in the tissues. That's hypoxemia.
So the body's not getting enough oxygen. It senses that, and it correctly tells the bone marrow, hey, make more carriers, make more red cells.
That's the idea. It's trying to compensate. The guide gives examples like severe chronic lung disease, certain heart conditions where blood flow is abnormal, living way up high at altitude,
right.
or even just the shape of brachycephalic breeds those flat-faced dogs, They can struggle to breathe efficiently. Other causes mentioned are things like certain blood disorders, methemoglobinemia, or issues with blood supply getting to the kidneys.
Okay, that's the appropriate EPO release. What's the second cause for secondary absolute?
The second one is when there's an inappropriate and excessive production of EPO, or something that acts like EPO, even though the animal has totally normal oxygen levels.
Huh. So the body doesn't need more red cells, but something is telling it to make them anyway?
Precisely. This is less common and usually points to something else going wrong often, the guide suggests. Rare tumors or lesions. These could be in the kidneys, like cysts or tumors, certain endocrine glands, or even some unexpected places. It's less about low oxygen and more about a specific problem lesion producing that EPO signal when it shouldn't be.
Okay, that clarifies the different routes. But why is having such a high PCV, all those extra red cells, actually a problem for the animal? What does it do?
This is really the crux of it. The core issue is hyperviscosity.
Hyperviscosity, thick blood.
Exactly. Think of trying to suck a really thick milkshake through a thin straw versus just drinking water. Hyperviscosity means the blood is too thick, too sludgy, because there are just too many cells packed in there.
Right, and thick blood wouldn't flow very well, I guess.
It absolutely doesn't. That leads to poor perfusion, poor blood flow getting out to the tissues. And even if you have lots of red cells, if that thick blood can't circulate efficiently, those tissues don't get enough oxygen. The guide really emphasizes that the severity of the clinical signs is directly related to how high the PCV gets, especially when it climbs over, say, 60–70%.
Wow. And which body systems really suffer from this thick, slow-moving blood?
The guide lists the big ones: cardiovascular, respiratory, nervous, and renal neurologic systems. Basically anywhere that absolutely relies on good, smooth blood flow to function properly.
So who tends to get this? Does the guide talk about signalment, like specific breeds or ages?
Yeah.
Any risk factors?
It's seen mainly in dogs and cats, as you'd expect.
Any particular breeds pop up more often?
Yes, breed can definitely play a role. The guide points out that brachycephalic breeds often have a naturally higher baseline PCV anyway.
Right, the flat-faced ones.
And large, excitable breeds. They're more prone to that transient type from the spleen contracting. And greyhounds are specifically mentioned. They typically have quite high PCV values normally. Their usual range is often 50–65%, which is, way higher than many other breeds.
Interesting. What about age or sex?
Yeah, for the primary and absolute types, it's usually seen in older animals. The guide mentions around 6–7 years for cats, maybe 7 years or older for dogs. And there's a bit of a sex difference noted too. Predominantly males in cats and females in dogs seem more prone to the absolute types.
Does geography matter, like where the animal lives?
It can. Altitude, definitely. The guide notes that normal reference intervals can vary. Animals living up high, say over 6,000 feet, typically have higher normal PCV values than animals at sea level.
Which makes sense. They're compensating for thinner air.
Exactly. Their bodies adapt.
So beyond those kinds of predispositions, breed, age, sex, altitude, are there other specific risk factors listed in the guide?
Not really. The guide states none specifically listed beyond those factors we just covered.
Okay, so let's talk about what you might actually see. If an animal has polycythemia, what are the clinical signs we should be aware of?
Well, the first thing the guide points out is that the signs can vary quite a bit. Depends on the degree of polycythemia, how high the PCV is, and of course the underlying cause.
Right. What might an owner notice at home? What history might they give the vet?
For that transient type, it might just be something noted right after the dog got really excited or had a burst of exercise. Pretty fleeting. For the absolute types, though, owners might report things like lethargy, the animal just isn't themselves, maybe a decreased appetite, sometimes nosebleeds. Epistaxis is the term.
Epistaxis.
Seizures can happen too, or maybe the owner just notices the gums look unusually red, like really red.
And what might a vet pick up on during the physical exam?
Okay, so if it's relative polycythemia, the vet's likely to see signs of dehydration. Maybe the animal's been vomiting, had diarrhea, isn't drinking, producing less urine, the usual dehydration signs. With absolute polycythemia, the findings can be more dramatic. Lethargy, definitely. Low exercise tolerance. Maybe behavioral changes. Those striking brick red mucous membranes are a big clue. Or sometimes they can even look bluish, cyanotic, despite all the red cells.
Bluish, how does that work with too many red cells? Seems backwards.
It does, right? But it can happen if the blood is so thick, the hyperviscosity is so bad that blood flow and oxygen delivery just plummet. Even with lots of red cells, they aren't getting where they need to go with oxygen. The guide also mentions things like sneezing, bilateral epistaxis, so nosebleeds from both nostrils. And looking closely, you might see large, twisted-looking blood vessels in the back of the eye, the retina, or under the tongue. Plus, of course, you might find signs related to whatever underlying heart or lung problem could be causing it.
Are there specific signs tied to the subtypes of absolute polycythemia, like primary versus secondary?
Yeah, there can be some differences. For primary absolute polycythemia vera, the guide notes you might find an enlarged spleen or liver, that's splenomegaly or hepatomegaly, sometimes evidence of blood clots, thrombosis, or even unusual bleeding hemorrhage. Seizures pop up occasionally too. For secondary absolute caused by tissue hypoxia, the low oxygen kind, you'll mainly see the signs of whatever's causing that low oxygen, like difficulty breathing from lung disease or signs of a heart condition.
Makes sense, treat the cause.
Right. And for secondary absolute from inappropriate EPO, the signs are usually linked to that underlying cause symptoms, maybe related to a hidden tumor or an endocrine disorder that's messing with EPO production.
Okay, so that's a lot of potential signs. How do vets piece this puzzle together? What's the diagnostic journey look like according to their guide?
Well, the usual starting point is running a complete blood count, the CBC, and measuring the total plasma protein, or TPP. If you see a moderately high PCV, and the TPP is also high, especially if the animal shows signs of dehydration, that strongly points towards relative polycythemia. The dehydration concentrates both the cells and the protein.
Okay, so that's maybe the easiest one to spot initially. Then it becomes about ruling other things out for the absolute types.
Exactly. The guide explains that primary absolute, the polycythemia vera, is often what they call a diagnosis of exclusion. You have to rule everything else out first. So you're actively looking for those diseases that cause the secondary type conditions causing chronic low oxygen, looking for lesions like kidney cysts or tumors, checking for endocrine problems, searching for other rare tumors that might produce EPO, or checking if the animal has actually been given EPO therapy for some reason, like treating anemia from kidney failure. That could cause it too.
Right. Are there tricky parts in interpreting those first blood tests, the PCV and TPP?
Yeah, the guide definitely flags that. Concurring conditions can really muddy the waters. Things like underlying anemia, low protein levels for other reasons, the dehydration itself changing things, or even if the animal has already received IV fluids before the blood was drawn. All that can complicate interpretation.
Okay, so what other tests become important then?
Measuring oxygen saturation, SO2, and EPO levels are pretty key for sorting out the absolute types.
But you mentioned EPO levels can be tricky. The guide says there's overlap.
It really can be. The guide notes there's quite a bit of overlap in the values between different types, and sometimes you can even see low or normal EPO levels in animals that do have secondary absolute polycythemia.
Huh. So it's not always a clear high-low situation.
Not always. That's why the guide mentions using specific labs, like the ones at University of Pennsylvania and Tennessee, that have really well-established reference intervals for EPO in dogs and cats.
Yeah.
That helps. And of course, hormone assays might be needed if you suspect an endocrine issue is driving inappropriate EPO production.
What about imaging? X-rays, ultrasound?
Oh, absolutely essential. Imaging like radiographs and ultrasonography are crucial for looking for underlying heart or lung disease, and also for finding those space-occupying lesions, things like kidney tumors, cysts, or other masses somewhere else in the body. That might be the hidden source of inappropriate EPO.
Any other diagnostic procedures mentioned?
Pulse oximetry is highlighted. That directly measures blood oxygen saturation, so it's really important for assessing hypoxemia, especially when you suspect secondary absolute polycythemia due to low oxygen.
The guide also mentions some specific findings if you look at tissues, like in polycythemia vera.
Yes, it does. If tissue samples are examined, say from a bone marrow biopsy or even post-mortem, the guide describes some specific findings for PV. Grossly, you might see generalized congestion in the blood vessels, maybe signs of clots in arteries, the spleen might be enlarged, and the bone marrow often looks really red and has less fat than usual. Microscopically in the marrow, it's hyperplastic, meaning overactive, churning out cells. but the ratio of developing white cells to red cell precursors might be normal or even low. And interestingly, the iron content is often reduced, despite all the red cell making.
That detailed breakdown, especially using things like PCV, TPP, SO2, EPO levels, really helps see how vets differentiate the types, like the guide lays out.
Yeah, it's critical. Like the guide summary table shows PCV is high in all types, right? But TPP is usually only high in the relative type because of dehydration. SaO2 points you towards secondary hypoxemia if it's low. And EPO levels, while tricky, combined with everything else, especially knowing that the bone marrow shows erythroid hyperplasia, that overproduction of red cells in all the absolute types, helps build the case.
Okay, really thorough diagnostic process. So, once the diagnosis is made, what does the guide say about treatment? How do you manage these conditions?
As you might guess, treatment is very, very dependent on the specific type of polycythemia that's been diagnosed.
Okay, let's start simple again. Relative polycythemia from dehydration.
Main thing is rehydration. Get fluids back into them, usually intravenously. The guide does stress that the type of fluid matters depending on why they got dehydrated. You need to assess kidney function, GI issues, acid-base balance, electrolytes, all that.
Right. Now, for the absolute types, where there's genuinely too many red cells being churned out.
The primary approach there is to reduce the total red cell mass. The main tool for that, recommended in the guide, is phlebotomy.
Phlebotomy like bloodletting, controlled blood removal.
Exactly, controlled removal of blood. The guide suggests a target like removing about 20 milliliters of blood per kilogram of body weight. This might be done all at once or spread over a day or several days, aiming to get the PCV down to a safer level, maybe around 55% initially.
But you can't just take that much blood out without causing other problems, can you? Like shock.
Absolutely not. And this is a huge critical point the guide emphasizes. You must replace the volume of blood removed concurrently with intravenous isotonic fluids. Like as you take blood out, fluids go in. Doing this is vital. It prevents really dangerous side effects like a sudden drop in blood pressure, cardiovascular collapse, or even paradoxically increasing the risk of blood clots forming because the remaining blood gets even thicker temporarily if you don't replace volume.
Okay, volume replacement is key with phlebotomy. Got it. So what about treating secondary absolute caused by that inappropriate EPO production?
It's often a two-pronged approach. Phlebotomy to get the red cell count down, and crucially, trying to identify and deal with the source of that excess EPO. So maybe surgery to remove a tumor, if that's possible and is the cause.
Right. Now, what about the tricky one? Secondary absolute caused by hypoxemia, the low oxygen. Because didn't we say the high PCV is the body trying to compensate?
Yes, exactly. And the guide is very, very cautious here. It explicitly notes that in these low oxygen cases, the high PCV is often a necessary compensatory response. So aggressively lowering it with phlebotomy can actually be dangerous and might make oxygen delivery even worse. If phlebotomy is deemed necessary, it needs to be done much more cautiously, maybe a slower rate, like only 5 millimole per kilogram removed.
And the target PCV might be different too? Keep it higher?
Yeah, the guide suggests that in these specific hypoxemic patients, a higher PCV, perhaps around 60–65%, might actually be needed just to sustain life until or if the underlying cause of the low oxygen can be fixed. It even states that phlebotomy might be completely contraindicated, meaning shouldn't be done at all in some of these patients. That's a really important distinction.
Wow, okay. Very careful balancing act there. What about the treatment for primary absolute polycythemia vera?
For PV, phlebotomy and the medication hydroxyurea are listed as the primary treatments. The frequency of the phlebotomy sessions and the dose of hydroxyurea are then adjusted based on regular blood work monitoring. Aiming to keep the PCV at a target level, the guide suggests around 55% in dogs and maybe 45% in cats.
Does the guide mention any other medications for PV besides hydroxyurea?
Yes, it does mention chlorambucil or busulfan as alternatives. It gives specific dosages too, like chlorambucil at 0.2 kilograms orally daily for both dogs and cats, and busulfan at 2 to 4 milligrams per square meter of body surface area orally daily for dogs.
Okay, let's talk a bit more about hydroxyurea since it seems key for PV. What sort of dosages are used and what are the side effects? It's a chemo drug, right?
It is, yeah. For PV, the guide suggests starting doses around 40 to 50 milligrams per kilogram orally, divided twice daily for dogs, and maybe 30 milligrams per kilogram once daily for cats. For secondary absolute due to hypoxemia, if it's used cautiously, the dose might be 40 to 50 kilograms orally, but only every 48 hours. And yes, because it works by suppressing bone marrow production, the potential adverse effects can be significant.
Suppressing production, even though the problem is production.
Well, the problem is overproduction, so the goal is to dial that down. But the drug isn't perfectly selective, so it can suppress all the cell lines produced in the marrow. This can lead to what's called marrow hypoplasia, dangerously low numbers of platelets, red cells, and white blood cells, big risk of bleeding or infection. Other side effects mentioned in the guide include hair loss, alopecia, changes in skin color, skin pigmentation, and sometimes even sloughing of toenails. And it specifically flags extra risk in cats developing methemoglobinemia or hemolytic anemia.
Okay, definitely serious potential side effects owners need to be aware of. What about general nursing care and management?
The guide mentions oxygen therapy might be necessary if the animal is showing cyanosis, has very low oxygen saturation readings, severe underlying heart or lung disease, or is just weak after a phlebotomy session. Activities should probably be limited, especially avoiding really strenuous exercise, particularly during phlebotomy periods. Diet is usually just normal, but free choice water should always be available, especially given the risk of dehydration making things worse.
And owner education must be huge with these conditions.
Absolutely critical. The guide really stresses this. Owners need clear instructions on what clinical signs to monitor for at home, any return of weakness, difficulty breathing, new bleeding episodes, signs of infection like fever or lethargy. And if chemotherapy drugs like hydroxyurea are being sent home, owners need thorough coaching on safe handling and administration, plus awareness of those potential side effects like the skin and nail issues.
Good point on safe handling. One last treatment question. Any special considerations if surgery becomes necessary for some other reason?
Yes, the guide makes a point here too. If a polycythemic patient needs surgery, very careful monitoring of their oxygen saturation using pulse oximetry throughout the whole anesthetic period is essential. The goal is to avoid letting them become hypoxemic during the stress of anesthesia and surgery.
Okay, that covers treatment thoroughly. Wrapping up this deep dive, let's touch on monitoring long-term potential complications and what the prognosis generally looks like.
Right. Monitoring is definitely key, and it varies. For those severely dehydrated animals with the relative type, the guide suggests monitoring PCV, TPP, urine output, and body weight pretty frequently, maybe 2 or 3 times a day, until they're confirmed to be normally hydrated again.
And for the patients with primary absolute polycythemia who are on chemo, like hydroxyurea,
Initially, monitoring needs to be quite intensive. The guide recommends weekly checks of PCV, white blood cells, and platelets to guide adjustments in medication dosage or decide when the next phlebotomy is needed. Once things are stable, this might be relaxed to monthly monitoring. The guide also advises periodically checking iron levels, either marrow iron stores or serum iron, because these animals can actually become iron deficient from all the blood draws and the body's constant effort to make more red cells.
iron deficiency. Interesting complication. What are the other main complications vets and owners need to watch out for?
The biggest ones, especially with absolute polycythemia and particularly the primary type PV, really stem from that hyperviscosity, the thick blood. It significantly increases the risk of thrombosis, blood clots forming where they shouldn't, potentially leading to infarction, which is tissue death from lack of blood supply. Or, conversely, it can sometimes lead to hemorrhage, abnormal bleeding.
Clots and bleeding. How does that work?
It seems paradoxical, but the abnormal flow dynamics and sometimes associated platelet issues in PV can lead to both. And then, as we discussed, chemotherapy itself carries the risk of bone marrow suppression. And that iron deficiency we just mentioned is another potential complication in the absolute types due to treatment and the disease process.
Okay, so finally, the big question. What's the prognosis? What's the expected outcome for animals diagnosed with polycythemia?
Yeah, the guide is very clear. The prognosis varies massively. It really depends almost entirely on the specific type of polycythemia and, crucially, the underlying cause.
Okay, so for relative polycythemia, the dehydration kind.
If you can identify and successfully correct the cause of the dehydration with the right fluid therapy, the polycythemia itself usually resolves completely. So the prognosis is generally fair to good, but it really hinges on how serious the underlying cause of the dehydration was.
What about secondary absolute due to hypoxemia, low oxygen?
There, the clinical course and the ultimate prognosis are really determined by how severe the underlying heart or lung disease is. If you can improve the heart or lung condition and manage the PCV cautiously to improve oxygen delivery, it might improve the animal's quality of life. But the prognosis often remains guarded because it depends so heavily on that primary, often chronic, disease.
Okay. And secondary absolute due to that inappropriate EPO secretion from a tumor or something.
That one's interesting. If the source of that excessive EPO, say, a specific kidney tumor, a cyst, an endocrine problem, can be successfully identified, A&E removed or corrected, then the polycythemia itself should completely resolve.
Right.
So the prognosis there can be good to fair, but again, it depends entirely on what that specific underlying cause is and how treatable it is. Removing a benign cyst is different from dealing with a malignant tumor.
Right. And lastly, primary absolute, polycythemia vera.
PV. Well, this is a chronic myeloproliferative disorder. It's a type of bone marrow disease. The guide says it does respond to treatment. The phlebotomy and chemotherapy can manage the condition, often for some time, but it requires lifelong, ongoing monitoring of blood values and constant vigilance for those clinical signs of complications, like bleeding, clotting, or decreased activity. Because it's an inherent bone marrow disease, the prognosis is ultimately considered guarded.
Wow. Okay. This deep dive, really digging into the guide, makes it so clear that polycythemia isn't just one simple thing, too many red cells. It's actually this umbrella term for several distinct conditions, each starting from different places, affecting the body in different ways, and needing really specific diagnostic and treatment plans.
Yeah.
Getting to the why are there too many red cells seems absolutely fundamental, and just like the guide stresses.
It really is. And it makes you appreciate just how interconnected everything is, doesn't it? Fluid balance affecting cell concentration, hormones from all over the body talking to the bone marrow, how well oxygen actually gets delivered, all these different systems playing a role in something that sounds as simple as just counting red blood cells.
It definitely does. It really makes you wonder, what other conditions out there involve such a complex interplay, where so many different body systems have to work together perfectly, or things can go quite wrong.